with Ricardo first. So, Ricardo, we've talked a little bit about, is there really a science for health? We're so good at creating models of disease, but how do you model the healthy state?
Yeah, totally. There is a huge problem in science generally that has to do with sampling and who you include in a data set and who you don't, right? So you have issues like survivorship bias, like you may be doing research on the people who show up as opposed to all of the population to find out what it is that caused them to show up and present themselves. So, in Alphabet we've been doing a few projects to try to understand health broadly based on a large number of sensors. My team worked on a study watch that was sort of an offshoot of an Android Wear device, but aimed at providing researchers with much better quality data so that they could begin to understand, what does health look like as opposed to disease. And now as we're working on, artificial intelligence and machine learning, we're facing all of the same issues. And you see them from consumer devices, like who gets included in a sample, to medical applications like, how does the doctor know that this prediction that came out of this black box is applicable to everybody, or is it applicable just to the people who were originally in the training set?
Mm-hmm. Sort of thought about designing LIFT sort of programs in healthcare. It's really been impressive to see what you've done. You've now integrated into 9 of the top 10 healthcare systems, integrated with all the top transportation brokers that traditionally service the healthcare industry, and you even have an EHR integration with Allscripts. So I'd love to have you tell us what you've learned as you've dug deeper into this sort of almost simple data point of missed appointments. So how have you dug deeper and expanded on the complexity of that?
Yeah, so when we got started in 2016, as you mentioned, I was at Google before, and really the whole impetus of this idea was looking at some of the work that Google was doing originally on autonomous vehicles and looking to transport people that were blind, elderly, or disabled. And there's some work that Google put out really showcasing and highlighting that use case. In my view, autonomous was still going to take 5 and potentially a decade before it would actually become fully adopted. And so that really inspired me to come to Lyft and really present this idea about how do we solve transportation for a traditionally underserved population. So the population we started with initially was Medicaid population and as well as Medicare. So looking at low-income, elderly populations and looking at the significant barrier that transportation had for those individuals. Today, 3.5 million Americans miss appointments every year due to a lack of transportation. And the lower income populations, around 1 in 4 miss appointments every single week. So it's a significant challenge to be able to provide care for those individuals. And what's tragic enough as well is that not only was it decreasing kind of the experience for the patient and also for the facilities, but also is costing payers a significant amount of downstream costs. It's estimated around $150 billion are lost every single year due to those missed appointments. And really simple use cases, like you take a patient who's on dialysis that every Monday, Wednesday, and Friday has to show up for treatment. If they miss an appointment on Friday, their mortality rate goes up by over 30% in the next 6 months, and it's estimated to cost payers $200,000 just for that one catastrophic event.
And you've used the term an ecosystem approach to health. So I'd love you to expand on what that means to you in terms of your overall.
Sure. So thanks for having me here today. Thanks for everyone who's paying attention. And I guess what I would say is when you get to Walmart and you step back and look at the breadth of associates we have, the mix of part-time, full-time, the turnover that exists in retail, you have to start challenging all the pillars that you started with. And so we had tenets that we had attached health promotion, health education, health improvement to. Things like you must be on the medical plan, right? That if you're on a medical plan, then it benefits. And what we saw was this entire ecosystem of people, some of whom were on the plan and some who weren't. And so ask yourself a question. When you go into a Walmart to shop, which I hope you do often because I have children that are putting through college, so I go frequently. When you do that, you don't care if the person who's checking you out is on the plan or not. And if they're diabetic, or if they're suffering from a chronic health condition, or some other major distraction that's impacting their ability to serve you, it's irrelevant if they're on the plan. You just want good service. So for us, we had to start challenging some of these tenets. So things like unlimited eligibility. So everything that our team tries to build is not just for the associate on the medical plan, but for anybody who works for us and the people they love. Which by default, when you look at the science, says that you're automatically in the community, right? Because the community is full of current, past, or future associates and people they love. So that began this journey for us. that led us from kind of the traditional model, which includes like health assessments and health education, into what I call applied behavior change, because we're learning so much more now. So that's how we started.
Yeah.
Where that's taken us is into some really interesting areas. Areas that led us to Kyra, which I'll talk about in just a second, but beyond the classic health habits of exercise and nutrition, and really understanding things like financial pressure.
Whenever they did the TMR, they told me 6 to 8 weeks is when you'll start feeling something. Don't worry about it until a week. I felt I was be able to differentiate between my two bicep muscles in 2 weeks.
Oh, really?
Yeah, it's blew my mind.
And you have sensation here?
No, I have no sensation right now.
Okay.
The only thing I do is like shake your hand.
But
I
you
look at the back of your hand, see how wide it is, so I know how far to bring this down to shake your hand.
okay.
So I don't hurt you.
So you don't crunch me.
Hey you guys, so I'm currently in the exhibit hall. This is where they have all of the different technology companies come and showcase their new innovations and their new ideas and literally get some networking done. So I'm going to stop by some stations and bring you in on some new innovations in healthcare technology.
How many sides do you have for the middle? Well, we're not sending you a bra.
This is my current respiration pattern. So I could click on this button here and this would coach me into a period of calm breathing. So
Wow, so that's the app. So you just go into it and it lets you know, like, hey, your heart rate's a little high, or you're breathing a little too heavy.
Exactly, and then you can review the past days. So what you'll notice here is I've got no gaps in my breathing data. So what that means is I've worn this every day, and the reason for that is because I put my underwear on every day. So even I can remember to do that.
And so we provide this all-inclusive service that makes it easier for someone to take care of themselves on a daily basis that has chronic conditions. So if you have diabetes, all the supplies are delivered right to your home, unlimited, so you don't have to hassle with your insurance company every time that you're running low on strips or every time you're running low on some part of the solution. Our meters are cellularly connected, so rather than someone having to fiddle with, am I connected to Bluetooth and on a Wi-Fi network, they don't have to think about it. They automatically goes up into the cloud. And we have a team of certified diabetes educators, nutritionists, and other health coaches who are monitoring the data and your trends and putting that together with other insights we know about you and your history and making sure that we're making it easier for you on a daily basis to stay healthy.
As you can see, the app is really dynamic. We tried to take into consideration co-designing it with the nurses and the moms in the program, as well as like the administrators of the program. What is missing? How can we fill these gaps with technology? And we came up with 5 different features. The primary one being a goal setting to keep the moms integrated in the program. program retention is something that both wanted to focus on. So building out SMART goals and teaching moms how to build long-term goals, short-term goals. You can add a goal. It's a really fun, dynamic platform. It makes it easy to want to write a goal, set a goal. They also have an entire section just for moms and nurses to communicate, so moms can plan ahead with their visits, what they want to talk about. If they have any concerns, they can reach their nurses directly, and the nurses can also see if the moms are following through on their goals or maintaining any achievements, and then directly congratulate them on the app. So it's very it's real time. You're getting, commended for the good work you're doing. It encourages you to kind of keep it up. And you can ask about topics for nurses. The home is also another place where it's just like the dashboard where you can see all of your goals, when your next visit is, and all the main points of the app. And then there's also a really awesome info center. So a lot of these moms don't have a lot of education surrounding pre and postnatal care. So you can find a lot of information about what your body's going to go through before and after pregnancy. If they have any questions about Medicare, Medicaid, any major questions that they have about what's going on with them, you could find it on the app. And then finally, this is my favorite feature, the mom community. It's a way to link all of the moms in the program over 42 states and a couple island communities in one area where you can ask for advice. You can meet other moms that might not be local, but that might have similar concerns as you, and it really builds this online community for the moms to feel supported.
Which is based on sound algorithms. They don't loop. It's really important not to have a sound that loops, because your brain detects the loop after you start sleeping to it, and it becomes even more disruptive to your sleep. So non-looping technology. These products right here are soundless sleep alarm. They feature a patented technology called adaptive sound.
We're a digital health platform. Anyone can use us. We're in the app stores for Google and iOS. You can also go to adaptidyou.com. We have the health store, which is what makes us unique. It's a real-time number from 1 to 1,000. It's based on clinical science. Underneath that, 3 main subcomponents: lifestyle, body, and mind. Lifestyle is movement, nutrition, sleep, and stress. Body is biometric data, mind is mental well-being. We capture a lot of this data through wearables or other sources like Fitbit, Garmin, Apple Health. Users can also manually enter that data. We ask questions through our digital AI coach. That's where we get the mind questions, since there's no really great trackers around that yet. All of that rolls up into the health store. This is my dashboard that I can customize, where I see the most meaningful things to me, my sleep, my activity. Most of this is coming from connected data sources, so my steps come from my phone. If I track a run on my Fitbit, that'll feed in there. I can track my sleep or manually enter it. We have a digital coach where I'll get questions around the things I'm interested in: nutrition, exercise, sleep, and stress. I can join goals around those areas as well and get personalized content. The coach will also ask questions that'll feed into the health store around my stress, my eating habits, my exercise habits. They're all easy one-click answers. So I get a question here about how many nuts I eat a day, or how many servings of nuts, and I can answer with an easy one-click answer. We have a social component where you can add friends, similar to other social networking sites. You can see their workouts. If you choose to share it, you can customize your privacy settings. The only thing users can share, if they elect, is their workouts, their health score, and their achievements. And you can set that privacy to be your friends, the groups you're in, or no one. You cannot share any personal health data. Here I have a friend request that I can accept. I can see the workouts for my friends, or if I'm in an employee group, my coworkers. We're a global company, so this gentleman has been running, it looks like, or walking in Switzerland, so it can be cool to see people you know, what they're doing. That motivates me to be more active when I see my coworkers or my friends out there running or walking or biking.
Why this hasn't been solved already, why this is so hard, because I think from the user standpoint, sometimes from the, even the tech developer standpoint, We just don't understand all the things that are in the way and why interoperability hasn't been solved yet.
So this is a great question, because it's like, I have friends in the financial services industry, and my office is right across the freeway from Visa up in Foster City. And they go, Dave, this can't be that hard. We've been exchanging data and authorizing credit transactions so that a credit terminal in Kathmandu can hit my charge card at Citibank and authorize my purchase in like a couple of seconds. What's the problem? Well, we have a maturity problem in that until we started implementing electronic health records, the health system was paper-based. You cannot compute paper, okay? So the past 15 years, we've been on this march to automate healthcare. It's fraught with a lot of issues, but we now have a vast availability of computable information. One of the issues that the federal government had when they incented the program was they also incented the creation of health information exchanges, or HIEs. The problem was one of timing. You cannot stand up HIEs when the primary object of your attention are health systems and physicians who are just now implementing the technology that needs to feed that. Well, that and combined with a really bad business model, but I won't go into that. So the time is right. EMRs are pretty ubiquitously deployed, as are a lot of the other supporting systems, whether it's lab or radiology, etc. And all that information now is reasonably computable, okay? It's still not perfect, because data standards and the data exchange standards, like ANSI X12 for administrative data and HL7 for clinical data, are still not sufficient to govern the exchanges of the information. They're too weak and they're too squishy, is the best word I can think of. So one of the things that we're looking to do is to use this moment in time to address the issue that we now have computable information that is insufficiently harmonized, and to do work on our own with the standards bodies, because you can't not support FHIR and X12 and the other standards, but we have to find a way to accelerate those to be more tightly granular transactions like the Federal Reserve Network, like SWIFT. And so that's where our energy is going here in the short term.
I wanted to start by asking you, what do you see between differences that you see between the US and the rest of the world? Also, can you talk a little bit about the trends in investment, because this is one of the things that you follow very closely as Startup Health?
Yeah, it's really interesting. As I was thinking about the discussion today, what we're really seeing is almost two parallel paths. There's one innovation path moving very quickly over the last 7 or 8 years, primarily in the US, but also globally, that I think is where billions of dollars are flowing, hundreds or even thousands of innovators being invested in, but they're working on innovations designed to layer on top of the legacy system. So they're working within the health system as it's been in the past and as it is today. And there's literally billions of dollars flowing in investment flowing into this. I think last year there was close to $12 billion that we tracked in digital health funding alone, globally. And the good news is we're seeing a lot of incremental progress. The challenge is, however, we're not seeing rapid adoption in many cases. There's very long sales cycles. There's many challenges to get people to change their behaviors or to adopt these new systems, whether it's the health providers or whether it's patients. We're pretty much seeing that trend across the innovation sphere. At the same time, I would say even over the last 12 months, we're seeing another parallel innovation path take shape around the world. And the reason I say around the world is because I was thinking it's really happening in China and India, but we're starting to also see it all over the world, and in particular, everywhere people have these devices, which is global. Even this past week with Apple's news, the past year with Amazon's news, what we're seeing are new innovators building on top of these other platforms. Platforms like Ping An Good Doctor in China, platforms like Apple's platform, platforms like Tencent. And these platforms are not health system platforms, they're new. They're largely mobile, they're largely using connected devices, and we're seeing the adoption rapidly take off. In many cases, in a matter of months, where consumers, because they don't have to change their day-to-day behavior patterns, are starting to use these new solutions that are essentially designed invisibly into other things they're already doing. So we can get into that, but just at a macro level, we're seeing these two innovation paths. By the way, I think they're both very important because we do need incremental innovation to fix many of the things of the system as it is, but we also need to leap forward. So just kind of a macro thought on what we're seeing broadly.
Can I just add one other quick thing? And I think, Pascal, you and I had the pleasure of being at the Health 2.0 in Barcelona, 6-7 years ago, or 7 years ago I moved to Europe, right? And I just remember some of these discussions with entrepreneurs where, in US, like, I'm gonna go start a startup, and you get a pat on the back, right? You're like, yeah, you go. In Europe, 7 years ago, I was like, what are you, crazy? You're gonna leave your job? You're gonna leave that, comfortable space? I think in the last 7 years, I've seen that ecosystem of VCs grow, much more entrepreneurship being kind of driven by, from within. And so I think the mindset of these entrepreneurs that are driving these changes along the existing value chains is just changing, right? So I think that's some very positive that I'm seeing around, whether it's Western Europe, Eastern Europe, irrelevant. So I just wanted to add to that.
Three things from a provider perspective to tackle that. And I can dive into detail on any one of these. But they are a doctor who truly knows you, a holistic, comprehensive plan, and an advanced data-driven approach where we're tracking outcomes over time. And we are fully direct to consumer.
So to the Apollo team member, I'm paying about $1,500 a year, is that right? And
little less than $5 a day, which I bet is less than you spent on your coffee this morning.
Well, I put it on my
specific to clinics or on the primary care side, I think what we've learned probably since the last time I was here is that if you were in retail and had a clinics business, your clinics are a disaster. They're it doesn't matter if it's us or CVS or Walgreens or Kroger, whoever it is. The clinics are a financial disaster first off, but secondarily they're providing almost no value in the market. They're not actually helping people get healthier. I guess it's nice if you've got strep throat, it will help you take care of that. And so we made a pretty hard pivot in the last 3 or 4 years to say we're going to actually focus on core needs. And so as we look at the services we're rendering, it's about not just taking care of the acute needs, but taking care of the chronic needs. And I think the interesting thing, we've now launched full primary care in 3 states. And you see the utilization of that is actually much more than we expected. It skews much more heavily towards individuals who have a chronic illness, are not getting the support they need from the traditional system, and are looking for someone to kind of help them. Interesting enough, we also have we've run some tests recently on the telehealth side with Doctors on Demand, and testing in markets where it's hard to staff a primary care physician or nurse practitioner, and even in those tests, we are seeing almost 3 times the rate of the individuals using them are using for a chronic need, not an acute need.
Two babies born at Gal Pacific. There you go. I got it. You have a new Porsche. Anyway. Yeah, so Sutter's the giant assignation was not about me, it was about the organization. I'm hardly a giant, but Sutter is really a large health system in Northern California, 3.5 million patients. And of course, one of the things I would reference is Susan's earlier remarks about sick care to health care, in that, we are in a state with the largest amount of diversity with respect to language, race, ethnicity, urban and rural, and so on. And having that number of patients in that database that we have through Epic, and also the connections that we have with other federally qualified health clinics and others, gives us, and we can talk about how well that works in terms of interoperability, but gives us the opportunity to really understand health communities very well, particularly things around health equity, and look for how to monitor, how to measure, and for potential solutions. It really gives us a laboratory, a playground to try to figure these things out.
We engage physicians, primary care physicians, in a way that I think no other organization has historically. We treat them like professionals. They don't work for us, we work for them. We bring them data and people and process into their practices in a way that they've generally never seen before, which allows them to deliver the kind of care that they want, and the results that we have really speak for themselves, because we drive tens of millions of dollars of savings across all these different population types while improving clinical outcomes. At the core from a technology standpoint of what we do is a proprietary operating system that we built called DocOS. And it's a system that, frankly, based upon my many years as a frustrated payer and then manager of a number of risk-bearing IPAs, is that we wanted to integrate with multiple different EMRs.